This is Pop Health Week streaming live on Healthcare Now Radio. I'm Gregg Masters, your co-host and executive producer, and joining me in the virtual studio is co-founder and principal co-host Fred Goldstein. Fred also wears the hat of president at Accountable Health, LLC. Pop Health Week is your go-to platform for peer-to-peer conversation with industry leaders, innovators, and ecosystem stakeholders, including payers, providers, patients, vendors, and the regulatory communities. We come together to swap the best ideas and strategies in population health management. Connect with us via www.popupstudio.productions or drop me a direct message on Twitter via @GreggMastersMPH, and that is Gregg with two G's. You can reach Fred direct via Twitter @FSGoldstein or www.accountablehealthllc.com. On this episode of Pop Health Week, we are in the company of Fazal Khan, MD, JD, Department Chair for Population Health and Professor of Health Law Policy and Management at the Meharry Medical College of Global Health. Dr. Khan brings a wealth of experience from his tenure at the University of Georgia School of Law, where his scholarly pursuits and pedagogical endeavors have centered on the intersection of law, healthcare, artificial intelligence, technology, and ethics. His scholarship, research, and teaching utilize an interdisciplinary approach to complex health issues, which include an array of groundbreaking research projects and seminal articles, such as the assessment of elder abuse laws, FDA law, and the regulation of epigenetic harms in consumer products. Notably, his work extends to ethical considerations surrounding human drug trials in developing countries and principles governing government accountability during public health emergencies. Dr. Khan's research has been funded by the NIH and ARC and has explored the ethical, legal, and social implications of epigenetics research. And with no further delay, Fred, the mic is yours.
Thanks so much, Gregg. And Dr. Khan, welcome to Pop Health Week.
Thank you. Glad to be here.
It's a pleasure to get you on to talk with another Pop Health person, a leader in the field. Why don't you tell us a little bit about your background?
Sure. So my name is Fazal Khan. I'm professor at the Meharry School of Global Health, which I just recently joined the faculty there. So it's a new program that started this year by Dean Daniel Dawes, who wrote this seminal piece on the political determinants of health. And I'm sure many of your listeners are familiar with social determinants of health and things such as, say, education, income, how it can affect healthcare, these different social factors. Political determinants of health looks more upstream, how different policy decisions, legal decisions by policymakers, government agencies affect our healthcare in different ways. And that was kind of the impetus for him to kind of start this new program, but then have this global focus. So that's why it's called the School of Global Health, because we're looking at how we can embrace this framework of the political determinants of health and apply that on a global level and see how we can achieve more global health equity and improve outcomes for populations. So that is kind of the mission for the school. So even though we're located in Nashville, we certainly are very invested in the Nashville community in Tennessee. We'll have a global outlook and work with partners, throughout the world, in Africa, Europe, Asia, South America, and we're kind of forming those partners and those networks to see what we can do to learn from them and what they can learn from us. And I'm really excited about this opportunity because for the last 10 years, and I'll just go back a little bit, before I joined Meharry, I was a law professor at the University of Georgia School of Law in Athens, where I focused on the regulation of emerging healthcare technologies. I started out focusing on pharma and kind of outsourcing of clinical drug trials. I'm about to say over the last 12 years, I really focused on the digital transformation of healthcare and the introduction of AI into healthcare spaces and how that's going to, and already has, dramatically transformed how healthcare is going to be provided. So with that background, I jumped at the opportunity to join the team at Meharry because I found that by going from the law side to the medical side, I can do more research and projects involving kind of how we can actually test these theories out in the field of making healthcare more accessible using technology. making healthcare more accessible by training, people, say non-MDs, to become community health workers and to go in the field and be augmented by AI and making AI more human-centered. So that has been kind of a thumbnail sketch of what I've been interested in, like how we can actually make AI be used for good. So I know there's all these scary scenarios involving Skynet and whatsoever, but I wouldn't necessarily say I'm an AI optimist, but I would call myself an AI realist. And that in some senses, AI integration in all industries, in all sectors, is inevitable, but we have a choice. And to me, this comes back to the political discussion. There are kind of political decisions that can be made to make sure that AI is human-centered, and it's not just about Silicon Valley, using capital and technology to replace all labor, which is kind of what they want to do, but making sure that we regulate in such a way that it's most beneficial for everyone.
And you also have a medical background, correct?
And so I'm a doctor and a lawyer. And then the funny thing is, so my parents are from India. And so when I told them, oh, I'm going to medical school, they're very happy. Some stereotypes are true, right? But when I told them I'm also going to law school, my mom's like, what? Why are you doing that? But for me, that decision really had to do with looking at the way healthcare has been in our country for a long time, that it doesn't work for everyone and that getting access to it is very difficult. So obviously being a doctor, being a nurse, you can do a lot of good for a patient on a one-on-one basis. And I think you're familiar with this, Fred, because you've worked with institutions. But in order to scale up that effect, you really need to address kind of policies related to healthcare. And so that's why I decided to do a joint degree program. I did this at the University of Illinois in the Medical Scholars Program, combining medicine and law, to see how we can really address some of these structural barriers to improving access, cost, and quality of healthcare in this country.
And before we get into some of those issues, Dr. Khan, could you give our audience a little introduction to Meharry Medical College?
Absolutely. So Meharry is a historically Black college university. It's a standalone medical institution that's been training doctors, nurses, and dentists for over 150 years. And some of your audience might be familiar with the Flexner Report. So the Flexner Report was this report commissioned by the Carnegie Foundation, and Abraham Flexner went around to the different American medical institutions, and the report was pretty scathing. He found that most of them were unfit, unqualified to train doctors in the modern medical sciences. And his kind of framework for determining whether or not a medical school is worthy of continuing was comparing it to what he saw in the great European capitals of in Berlin, London, and Paris, where they were using the latest scientific methods, techniques, and he found that lacking at a lot of American medical colleges. So this led to the traditional narratives, a lot of reform in medical schools where they became more rigorous, had a more focus on basic sciences. So that's why in medical school, even today, you see kind of this kind of Flexner kind of framework where you'd have 2 years of basic sciences, and then your third and fourth years of med student is when you start going into the clinic and the hospital, actually seeing patients. That comes from Flexner. But what's not discussed as much is what critics are now kind of talking about is kind of the racist overtones of his report, where he recommended that out of the existing 7 historically Black medical colleges, that the vast majority of them should be shut down because they didn't meet his standards. And you say, okay, well, maybe that was a fair assessment, but when you read some of his other statements, such as African Americans really should only be involved in, say, janitorial services in the healthcare profession, you can see how there's a lot of bias involved. So Meharry was one of only 2 historically Black colleges that survived the Flexner Report and kept their medical institution going. The other was Howard University. So there's a long history of Meharry kind of being singular in kind of training, future for African American doctors, nurses, and dentists. And some even say without their dental program, we wouldn't have the amount of African American dentists we have today, because generationally they just wouldn't exist. And so that's kind of Meharry's kind of important historical background. And now going into the future, we see Meharry as kind of leading, not in only providing healthcare to, say, historically underserved communities in the U.S., but also kind of expanding that focus globally, because we really want to be leaders in this area on a global level. And that's kind of what's the impetus for the School of Global Health getting kicked off the ground.
That's really a huge lift, obviously, with the School of Global Health. And I'm thinking about all these things going in my head from a policy perspective and looking at it, as you talked about, from politically and because countries can be so different in how they operate. So do you have some central themes within that you're looking at?
Yeah. So one area that I'm looking at is, for lack of a better term, inclusive AI. Because as you know, these AI algorithms really are only as good as the data they're built upon. So we've seen, and there's a lot of studies confirm this, that if you have a system where there's a lot of bias in the data that reflects, structural inequities in healthcare and not providing, timely access to, say, diabetes care, cardiovascular care to minority populations, when you kind of input all that data and then you kind of try to find, answers, sometimes the answers you get back are suboptimal, right, for different populations. And you're only scaling up the discrimination that already kind of pre-existed. And so making sure that the AI doesn't reinforce biased, treatment decisions is important. And also, some of these data sets simply don't have enough minority populations within them. So they're only pulling from data sets where they're kind of overrepresentation of the Caucasian populations, underrepresentation of African American, Hispanic populations. So that again can make some of the AI recommendations not as robust or strong as they could be in a positive sense. And so one of the initiatives that I want to get off the ground in conjunction with our team at Meharry is to kind of reach out to some of these communities and first kind of get their assessment of what they think about AI and it being kind of more incorporated in healthcare, rather than just saying, we're going to pose this upon you. It's like, what are your thoughts here? Because it kind of recalls to me the study that was done in these nursing homes involving robotics and elder care. Because as you might know, in Japan, which has a very older population, right, they're probably 10 years ahead of us when it comes to using robotics in different areas of healthcare. They asked kind of these US kind of assisted living patients, this is what they're doing in Japan. Would you be interested in having these robot assistants who can help you with the activities of daily living? And it was interesting. The results, a lot of these, assisted living patients said, yeah, that'd be great. They can help me with cooking, cleaning, doing these other things, these robots. But one question they asked, which was kind of chilling for me, is like, do we have to do what the robots tell us to do? So there's a sense that somehow this technology was not always for their benefit and that they might lose some of their autonomy and control. And so I see the same issue not only for the elderly, which I would consider in that situation a vulnerable population, right? If some of their physical, mental faculties are declining to the point where they need this assistance, but also vulnerable populations that have been kind of on the outside of kind of receiving healthcare services. And I think we really have to be cognizant of, if we're going to be using these new technologies such as AI and automation, are we really doing it for the benefit of these communities? And what are they saying about it? So that's, for me, is like an important threshold question. Like, what are these communities that have been traditionally underserved? What are their attitudes? And then kind of doing testing, saying, okay, can we actually improve outcomes by using this technology? Do we see better outcomes in different areas of, disease prevention, chronic disease management? And that's kind of, initially where I want to go. And then obviously look at the broader political economy implications, because kind of workforce displacement is a big concern of mine when it comes to AI and healthcare. Because you go to a lot of communities, and this stems from my experience when I was at UJ in Athens. I started this rural healthcare symposium where we were talking to doctors and nurses in these rural areas of Georgia. And they were telling us well before it was a national discussion point about the opioid crisis, how it was devastating these communities. And so we convened not only the providers from rural areas, but also like legislators, policymakers at the national level to come together and discuss these issues. And of course, technology was always a big part of our discussion. Like, how do we kind of use telehealth, AI to kind of reach these communities? How do we incorporate ride sharing services? So someone in a rural community who needs to go to a doctor's appointment 45 minutes away doesn't call an ambulance, right? And that actually happens in some of these communities, unfortunately. And so, coming from that background, looking at underserved rural communities, underserved urban communities, I'm optimistic that technology can be a part of the solution, but also wary that it also could have unintended effects, such as like I said, going back to these rural communities, and some of them, the only middle class job growth there is in the healthcare center, where you have the nurses, you have doctors, and med techs. They're the ones who are supporting local restaurants, buying new cars, et cetera. If you automate all of that away, what's going to happen to those communities? And like I said, from my experience in Georgia, we've seen when a hospital leaves rural community, good luck getting any new investment there, right? There's no new factories coming there. There's no new jobs coming there because, they'll look at and say, well, there's not a hospital within, an hour distance of this community, and they slowly kind of die away. And if we replace all the, human healthcare providers in these areas and automate it, I think it might just rapidly increase that cycle of decline in these communities, which then in turn leads to these diseases of despair, such as the opioid abuse. So to me, it's all connected.
For those just joining us, we are in the company of Fazal Khan, MD, JD, Department Chair for Population Health and Professor of Health Law, Policy, and Management at Meharry Medical College School of Global Health. Stay tuned for the rest of the story.
Right, and you sort of taken it to a certain point where you talk about the fact that if we use AI, and there is, this burgeoning belief that AI and new technology is going to allow us to bridge that gap and finally solve it. But as you point out, maybe there are some problems there, maybe it won't. But if it does, and then there are no jobs, as you talked about, what's sort of the next step? Yeah, we've talked to some people on here about, basic income and things like that being espoused as ways to potentially solve that, because they've talked about potentially in one of the other shows we had, maybe 30% of the people would be losing their jobs because of these new technologies. Is that sort of where you think it might go, or any thoughts on that?
Yeah, it certainly is a possibility. Like in the short term, I'd say over the next 10 years or so, I don't see AI replacing doctors and nurses. What I do see doing is that healthcare institutions that aren't using AI are going to be replaced by healthcare institutions that are using AI within their organizations. And to me, that applies to every field, including the law and medicine, you name it. So I would see in the initial phase, you have augmentation of people's abilities, and you'll see increased productivity. And there's some data indicating that we're already seeing some of these productivity gains from the use of AI. It's still kind of murky. There's a lot you have to parse through the data, but I think it's a real effect. But going forward, you can imagine that, okay, you have this increased productivity. They'll reach to this certain level where there's only so much more you can do as an individual, even with the help of this technology, before the logic is, well, we'll just automate as much as we can, because the biggest cost for any organizations has always been labor, right? Labor, benefits, et cetera. And if you replace that with an algorithm up there in the cloud, and you just save a lot of money, right? So the question becomes, what do you do with all these people who've been replaced, whatever the percentage is, whether it's 30%, 10%, whatever, it's still pretty significant. So yeah, obviously UBI has been discussed and theorized for a long time as a potential solution.
So you've talked about taking this out in the community. It takes away some jobs. The next step is, what do these people do? And so a lot of people talk about universal basic income as a way to solve that. Is that sort of what you're considering?
Yeah, I think that's a potential solution. But I'm not sure it's the ideal solution, because if you're saying, okay, you lost your job, now we're getting this basic income so you can, pay for the basics of living. It concerns me that if large segments of population don't have, some type of purpose, will that lead to more use of drugs, more reliance on, things that I would not consider to be good. Like we've seen, like already, cheap access to drugs, pornography, these other things, it can be very damaging to society at scale. And if we're not providing the opportunities, capabilities to provide meaningful, employment or other things for people in society, I am concerned where that leads in the long term. And kind of just relying on UBI I think it's maybe just a short-term solution.
And this is sort of like the way we've talked about it so far, sort of a US centric or a US look at this issue. Is it similar when you start to begin to look at this overseas and the impact of AI and new technologies, or is it different just because of where these countries may be at in terms of their economic development, et cetera?
Yeah, no, that's a great question. So if you look at some of the countries in global south, since they don't have the same infrastructure that we have, take one example with kind of mobile banking, they leapfrogged us. So if you look at Kenya, South Africa, they didn't have the robust banking infrastructures, ATMs, et cetera, that we have. But once the technology for digital transfers over your phone came about, they're far ahead of us when it comes to penetration of mobile banking, and they've been doing that for much longer than we have at scale. And so I do see the opportunity for some of these developing countries to kind of skip ahead and have a healthcare system that is much more based on automation and integration of AI, paradoxically, than we are, because we already have this kind of embedded, developed healthcare system where it'd be very disruptive to now tell all these doctors, nurses, med techs, you need to reskill, redo what you've been doing before. Whereas you go into, say certain parts of India or Africa, they don't have that. So it's much easier to transition to this newer form of healthcare delivery, if that makes sense.
Sure does. And think about this a little more narrowly. Where do you see AI and these new techs playing a role in population health?
So obviously, AI relies on data, and it can find a lot of insights and kind of massive amounts of data. So feeding in all these population health level data, I think we'll start to see a lot more kind of correlations between different exposures and kind of healthy outcomes. I think it will lead to development of more precision medicine, where we can tailor healthcare to individuals' profile backgrounds. So in two different ways, I think it can give us better insights at the population level, but also at the individual level, because all of that's reliant on data. And now we have the capacity with the amounts of data, and also the level of compute has increased so much as well.
Mm-hmm. And one of the things we've touched on this a little bit is we always talk about AI and these new technologies as being a corporate deal. The companies are going to put this new AI in. They're going to do this to analyze that, et cetera, et cetera. I've sort of been thinking about this, and we've discussed a bit of putting AI in the hands of the consumer, and particularly those in disadvantaged populations. Do you see some opportunities there?
Absolutely. And I think that goes towards making AI inclusive and making it human-centered, where individuals out in the community can control how it's being used rather than having it imposed upon them, by their healthcare provider. And so, yeah, I do think that would be a beneficial outcome if they were given that level of control.
And obviously, the systems would have to be designed so, one, they are inclusive. Two, the information they're providing is correct and not some hallucination, as we see sometimes. But I do think there's a great opportunity for that. So where do we go from here? Where do you go from here with Meharry?
So I'm really excited to be at Meharry, just because we're starting a new program from the ground up, so we can make it what we want it to be. And for me personally, with my focus on AI and healthcare, I really want to, see how we can, like I said, make it more inclusive, address inequities in healthcare, and maybe achieve the triple aim in healthcare, right, which is increasing access, lowering costs, and improving quality. And without AI, I don't see how we reach that goal, because obviously the Affordable Care Act increased access, was not so great in terms of bending the cost curve. Quality maybe is a wash, but with AI, you can see how that is possible. But I do think we have to make the proper, policy decisions to make sure that we're not causing so much disruption within the healthcare markets.
Mm-hmm. And you also talked about, what was fascinating, was community health workers. So we're talking AI, we're talking about community health workers, which is sort of the whole opposite end of that spectrum. But really, we need both, right?
Oh, absolutely, we need both. Yeah. And so when it comes to like the shortage of doctors and nurses is projected, because we're getting older, they're retiring, and we're living longer with chronic disease. I think roughly 100,000 or more shortage of doctors predicted in the next decade. You can't train more doctors. We don't have enough capacity in med schools. So one of the things I proposed in my writing was, what if you had community healthcare workers who trained alongside doctors and nurses and this technology that's kind of augmenting them, so they know when to kick up a more complex case to a nurse practitioner or a doctor, when it's something that they can treat, and the AI will be there to backstop them. And for me, this is a way of people from the community who are in this program know their neighbors, can have this kind of intimate knowledge of their community, but also this technology backing them up, and the overall healthcare team along the whole continuum of doctors and nurses that they can rely upon. And for me, that is a good use case for AI that is human-centered and improves community health outcomes.
So you're essentially picturing the CHW in the community with the augmented intelligence on their phone or something like that as they work with individuals.
Absolutely, yeah.
Wow,
and we see proto examples that's already being done, but I want to see how it works at scale.
Right, and so you plan to be testing that at Meharry, concepts like that?
That is one of the goals. Yeah, that's one of it. So we're in contact with some donor and grant foundations. So fingers crossed. Yeah, we'll come on the show like in a year or so and say, yeah, we got the funding for this.
Well, that's fascinating. I certainly hope you get the funding. I think that would be great to test it. And we definitely would love to have you back on to discuss that once you get that up and running, to hear how that's going, because I think that is sort of the melding of that community, being out there with them, with the technology to try to create, and as you said, achieve the triple aim. So thanks so much for joining us today, Dr. Khan. It's really been our pleasure.
Oh, thank you. Really enjoyed this.
And back to you, Greg.
And there you have it, folks. That's a wrap on today's broadcast. We want to extend appreciation to our worldwide listeners for tuning in, and our deep gratitude to Fazal Khan, MD, JD, Department Chair for Population Health and Professor of Health Law, Policy, and Management at the Meharry Medical College School of Global Health. Do follow his important work on the web via www.meharryglobal.org and on LinkedIn via linkedin.com/company/Meharry Global. If you find our work at PopHealth Week engaging, please show your support. Give us a thumbs up on your favorite podcast platform. Share it with your colleagues, and do subscribe to ensure you don't miss out on future episodes. Remember, we're live on Healthcare Now Radio weekdays at 5:30 a.m., 1:30 p.m., and 9:30 p.m. Eastern. And for our friends on the West Coast, that's 2:30 a.m., 10:30 a.m., and 6:30 p.m. Pacific. From all of us at PopHealth Week, Fred Goldstein and yours truly, Gregg Masters, we urge you to stay safe. Fare thee well.